So we had a question come up in the chat. Someone wanted to talk about the month-long injectable therapy for HIV, and they were feeling that it is a step towards a cure. And we're basically sharing, won't it be better than taking pills? Do you feel that long-term injectables are a step towards a cure or toward a remission? Or are they just more about improving people's quality of life so much so that it seems like it's a closer to cure? What do you guys think?
I mean, I think that that there are two parallel developments happening, right? We want the cure, but we also want more sustainable ways to manage people living with HIV and the onerous of therapy. So I think the long-term acting is moving forward very aggressively. So I think that next year's CROI, maybe we'll be talking about long-term acting is now becoming more accessible, and now then the question is, if you have the option to be on a 1-year dosing regimen,
Mm-hmm.
do we still think about the cure agenda in the same way?
Mm-hmm.
Now, obviously, that's not going to be the answer for everybody, because even now they're talking about, well, how do those types of approaches line up with therapy interruption sequences, or how do they align with life of a woman that wants to be pregnant, and start a family. So it's not going to be the answer to everything, but it's certainly going to change the way we think about options, I think.
Right, we're not going to be able to do treatment interruptions in the same way. Definitely, that's one thing that would be affected. If it's a year-long treatment, they're not going to be able to necessarily join a study that's requiring them to go off therapy until their therapy wears out for that year. Right. Like that'll be definitely a wrinkle. Did Anne or Brad want to add anything?
I'll just say that in terms of the the long-acting therapies that we have in hand now, the injectable cabotegravir and rilpivirine combination that's FDA approved, there was data that was presented saying, showing that basically every 4 weeks seems to be, or giving it every 8 weeks rather than 4 weeks is non-inferior. And I think that's already been pretty much known from prior studies, but it wasn't FDA approved for the every 4 weeks. So now at least it probably will be.
Mm-hmm.
So that's getting, we're not at the year in terms of actually clinically available drugs yet, but we're getting, a little bit closer.
And the every 8 weeks has been submitted to the FDA for approval.
Okay, I didn't know that. That's good.
So go ahead. Did you? Who was there? Sorry.
Linda has a quick question. Her hand is raised.
Okay, go ahead.
Linda, please come off mute.
Sorry, yeah, I had to unmute. But that's really not, those long-acting drugs are really not cures, that where you won't be doing, unless you have really, Visconti type exceptional data. They're not really about cures. People
absolutely, Linda, I agree with you.
They'll still have to do that, and if you think about the people in Africa that are still getting drugs like that we had 15 years ago. I think that remains a huge issue. What we'd like to do is make sure, that eventually you'll have some sort of a cure as opposed to not.
Right. And
and they're more about ease of administration and adherence, I think. And the other thing is, as was said, you have to see your doctor once a month. So most people go in every 6 months or you know what I mean? So think if you had a practice and all of a sudden half of your patients had to see you once a month as opposed to once every 6 months. That's a pretty big lift for most physicians and practices.
Right. And as someone pointed out in the chat, the injectables still will have side effects that they're going to have to deal with coming off of them, or how do you switch? That's going to be another issue. There's going to be lots of issues besides that clinical issue of, if everybody's on this, you're going to have to change the way clinics operate, because people are going to be coming into the clinic a heck of a lot more. And I think that is definitely something that I know in Seattle they are thinking about, and how are they going to do that. But also remember, the research is always trying to improve itself. I think hopefully we're going to go for subcutaneous, maybe self-injections, so people won't eventually have to come into the clinic. I think that's where the long-acting injectables are moving towards, where we can have people go in less frequently, but collect a bunch of medicine and have a bunch of needles and be more like the insulin treatments that my friend with type 1 diabetes might have to take. Making HIV that type of treatment. So
there's a lot of oral drugs too in the pipeline to do the same thing. So, and I think as Luis was saying, the question will be, do we need to spend all this money on cure research if we can have drugs that we only need to take once a year, which we're pretty far away from that at this juncture. But I mean, once drugs start to roll out, they speed up. Things tend to speed up pretty quickly once they figure out certain things. It's not like us that the more we do, the more questions we have.
I would love to ask the other people attending this call right now. What do you think? What do you think about this issue? Speak up. I would love to hear what you are thinking. What if we have a pill that you have to take once a year? Would you still want to see a cure?
Richard Jeffries in the chat says yes.
Let me add, as somebody who went in for weekly allergy shots, it's a real system. I went in and I was out of the office within 5 minutes for my weekly allergy shots. Wow. So clinics, you're not going to see a doctor. You're going to go in, you're going to see an RN, you're going to get a shot, you're going to be gone in 5 minutes. So this is going to be very fast. It's not going to be a burden for any of the doctors, trust me.
Right. Thank you. Thank you for letting us know. Yes, and I see a lot of people saying yes, absolutely.
Yes.
In the irony, not the irony, but the complexity is that, as you know, cure-related research requires really high levels of commitment and understanding of what the entire objectives of these studies are trying to accomplish. And the same individuals that are the most informed and most committed are probably the ones that are also most aware of what developments are for new therapies. So the question would be, how many of these individuals will transition into long-term ART, and that are the same type of groups that we kind of have been working with towards a cure agenda, because these studies are very demanding. So it really requires someone to be very invested in the cure agenda. But they're also very informed at the same time.
Right. I'm reading a lot of the responses. Thank you for giving us your thoughts here. This is really appreciated, because we wonder about these things. I often wonder how it will affect the advocacy around the cure. Will there still be a push or a need? And I think that's why it's important for us to get a global perspective in, and making sure that community from everywhere, not just the US or not just from Europe or not just from Australia, but everywhere, so we can have a more robust response to that type of question, because we might get content with ourselves in high income countries that might have good healthcare, but there's still a lot of people who don't even have access yet to regular ART.
Right.
And we still need to take care of that before we can even ever let go of a cure. And they're the people online always that I hear clamoring for a cure, crying out every day, cure us, cure us, cure us.